What I want to talk about today is how to translate the current best practices of osteoarthritis into patient action. That's one of the mandates of the OASIS program. It's a Vancouver Coastal Health program. It's an acronym that stands for Osteoarthritis Service Integration. Our goal is to help people manage their condition, delay the progression of the disease, and avoid preventable declines in health. So to that end, today I'm going to talk a little bit about chronic disease self-management and with a primary focus on what is the current best evidence in terms of pharmacological and non-pharmacological strategies in managing OA. So, as mentioned, the Osteoarthritis Service Integration Program is specific to Vancouver. Our program is focused on assessment. We have a multidisciplinary assessment clinic that is staffed by a physio, nurse, and OT. Patients are referred to us by GPs. They have an assessment done by the team, and they leave with an action plan. So what are the action items they can do, again, to manage their condition? I, as an educator, provide a number of education strategies along with our education team. We have classes in pain and osteoarthritis, exercise osteoarthritis, nutrition, mindful eating, pole walking. We have a variety of surgical optimization education classes. All of these resources are available on our website, or if you're interested in the PowerPoints or handouts. By way of example, I've provided you with some of our recent handouts. So there's a osteoarthritis protecting the joints in your legs and feet, osteoarthritis protecting the joints in your hands, also Nordic pole walking, which is a personal favorite of mine. All of these are meant to be tools that you can give your patient. So when you have somebody come to your office who has osteoarthritis, who is at risk for the pharmacological management strategies, giving you the opportunity to say to your patient, you know what, there's something you can do every day to help the health of your joints. Why don't we look at your nutrition? Why don't we look at your exercise, joint protection, that sort of thing. One of the mandates of our program is knowledge transfer. Our goal is to pass on the resources we have to you. And so at the back table, I just want to draw your attention to a booklet. Let's say you have someone who is newly diagnosed with osteoarthritis. This is a nice little quickie overview of what it is and how it works. And it is on the back resource smorgasbord table. Also, there's a DVD. This is an hour of people who have arthritis talking about what can you do to what do I do to manage my joints in terms of nutrition, exercise, joint protection. So if you have any interest in this kind of resource, I would encourage you to help yourself at the back table, or at a later date, if you'd like a stash of DVDs, if you want to be able to hand one of these to your patient as they come through, please contact me and I'm happy to provide those. The other document that I gave you is the basis of today's talk. There's a thing called, actually, one moment please. There we go. OARSI. OARSI is Osteoarthritis Research Society International. That's kind of the cornerstone of where we go looking for what is the current evidence for managing OA. They have a great website, and on their website they have what's called the OARSI Primer. And from there I pulled off this table to support what we're going to be talking about today. It looks at, the thing I love about OARSI is they've done the meta-analysis for us. So they've looked at the random control trials, they've looked across the planet, who's doing research on OA, what is the effect size, what's the number needed to treat. So here's a document summarizing that's in your package. Some additional supports to the content I'm giving you today is the European League Against Rheumatism, and the American College of Rheumatology came out with a set of guidelines, April 2012. I can't get any more current than that. And so you have a copy of that as well, talking about pharmacological, non-pharmacological. I think the thing with osteoarthritis is sometimes it seems like the same messages over and over, but what I really like is that there is this analysis of what is the current best practice, and that's what we're going to talk about today. What I find kind of interesting, though, is sometimes the recommendations from OARSI are not the same as the recommendations from the American College of Rheumatology, which is where expert consensus comes in. I think when it comes to osteoarthritis, a lot of times you'll have your opinions, I've got my opinions, the experts have their opinions, There's no absolute 100% excellent strategy for OA. A lot of them have actually small effect size. So it really comes down to you deciding what is it that you can get behind and what can you encourage your patients to do. So actually recently the GPSC asked me to run a focus group with patients to talk about what was it like when you were first diagnosed with OA. And the story I heard was somewhat akin to the scenario I provide here. So you've got an obese patient who is diabetic, hypertensive, sedentary, suffering. They've got moderate, he or she has moderate OA in the knees. And the response a lot of people feel they get is, well, you're too young for joint replacement and anti-inflammatories are bad. And you know what, you're too young for surgery. You need to lose some weight. And people leave with an overall bleak perception of how the overall trajectory of how their OA is going to go. A number of people talked to me about how depressed they were, how fearful they felt. They thought, wow, I got this diagnosis. It's sort of like the first message you get that time marches on and you're actually getting older. What it seems to me is sometimes the way we present this message influences if people have the confidence to actually take action and do something about it, as opposed to perhaps reach for those comforting strategies that aggravate it, like the drinking, the smoking, the high-fat food. So what I'm hoping is, as we go through this, you can think of action-based items to give your patients so that when you give them the diagnosis, you can also give them some tips on what can you do to delay the progression of your disease. A lot of different things contribute to OA. You know this. Sometimes I don't know if we're always so comprehensive in our approach to managing it. So a multifactorial cause requires a multifactorial management plan. As was mentioned earlier in the return to work session, this idea of making it patient-focused. You aren't driving the bus. You can't be the policeman or the guardian of how people manage their health. When it comes to managing a chronic long-term condition like OA, it has to be patient-focused. It has to be, like, you can give 1,000 recommendations, but if your patient isn't going to do them, it's a waste of your time and it's a waste of their time. So what we're going to talk about today are what are some pharmacological strategies you can offer? What are some non-pharm strategies you can offer? I teach a 2-hour pain class, and one of the biggest management strategies I give people is, you know what, write stuff down. Get yourself a blank notebook and get clear on exactly what's the problem, what's bothering you, and what are you doing to fix it. The act of putting pen to paper significantly increases people's compliance and ability to sustain a change in lifestyle. Also, I've had people say to me, you know, I've spent $3,000 at physio and it hasn't helped. And I always say, you know, it's too bad you didn't stop at 1,000 and go to Hawaii, right? You have to be clear on the fact that arthritis is a growth industry and people can spend an infinite amount of money on strategies that may or may not work, or may in fact make their health worse. So I always say to people, get yourself a health dog, write down what you're doing, and use this as a tool. So when you have that 10, 15 minutes with your GP, you can be clear on, here's my priority problem, here's what I'm doing. It's patient focused. Here's what I have done to help myself. What do you think, doc? Another example, there was a woman who told me she was taking a few Advil once in a while. It worked. Her joint got worse. She took some more. Joint got worse. She took some more. She went to her doctor. She was hypertensive. He put her on diuretics. And I said, well, did you mention the Advil thing? And she was like, well, no, I just get it over the counter. So helping people understand that all those over-the-counter items that are available to treat arthritis have their own risks and benefits. And how can your doctor make the right choice if you're not giving them the information? So that's a message I certainly give patients is be clear on what you're doing, when you're doing it, and put it in the form of a SMART goal. So that you know, when you have the person who rides in on their scooter and they've got short knee or painful knees, and you say, well, you need to lose some weight. Well, that's kind of a big broad, who knows if you're ever going to do it and what does it actually mean? Instead, what we tell people to do is set SMART goals. So SMART being specific, measurable, action-based, realistic, and timely. So instead of saying, you know, you need to lose some weight or whatever, getting specific on exactly what you want to do. What I would love is for you to have a prescription pad that includes fruits and vegetables and like a fry abolition for the week or something. But just trying to get clear on helping people take specific action. So, as mentioned, the strategies we're going to review are from the OARSI primer, which is from the OARSI website. In terms of your table, effect size, 0.2 is small, 0.5 is moderate, and 0.8 is large. What you'll notice in both pharmacological and non-pharm is that the effect size for osteoarthritis strategies tends to be small. For that reason, and what another part of that is, so you've got small effect size for the pharm strategies, you've got small effect for the non-pharm strategies, but the non-pharmacological stuff tends to have far fewer side effects. So isn't it interesting that we tend to be more inclined to take the pharmacological approach when you can have comparable benefit and lower risk by looking at the non-pharmacological strategies? So, the menu of options for pharmacological strategies according to OARSI. These are the items that are currently recommended to manage arthritis. These are the pharm strategies you might be suggesting already, but I will go through blow by blow and talk about, do they work, do they not? So first of all, in the realm of topicals, capsaicin is kind of old school, but it turns out it has actually, that's one of the ones that doesn't have a clear effect size, I believe. Yes. So just because it's not on here doesn't mean it doesn't work. It means that I don't know if anyone can really turn a dollar from proving that capsaicin works, but it does. It depletes one of the substances that contributes to the transmission of pain. So again, this is, when it comes to a chronic disease, you got to manage it in a chronic way. Capsaicin once in a blue moon isn't going to work. Capsaicin done 3 to 4 times a day to the same joint, that's the thing that makes that work. So making sure your patient understands that, because sometimes when you make these recommendations, they'll apply it when it hurts. Well, that's not actually the mechanism of action. So specifically, capsaicin is effective on hands and knees, and it's usually going to max out at about 2 weeks. So you might say to your patient, you know what, give capsaicin a 2-week trial and let's see how you're doing. Write it down in your health log. Write down how much you spent on it. And at the end of 2 weeks, are you feeling better or are you not? And if anyone's ever cooked with cayenne peppers, please be aware of that whole, for the love of Pete, wash your hands or you'll end up with cayenne pepper in your eye, you know. And also, so your patients who have, say, psoriasis or eczema or any kind of skin irritation, this obviously would not be the right choice. Moving on, what I was surprised by in the research is the effect size for topical NSAIDs. That's actually better than a lot of the pharmacological options, and yet topical NSAIDs aren't typically, in my neighborhood, they're not as frequently used as I would like. It seems like there's a tendency to go towards oral ahead of topical, when in fact topical can be quite effective. The topical that is considered currently most effective for osteoarthritis is diclofenac, so Voltaren or Pennsaid. There's significantly lower side effects. So you got somebody with a cardiovascular history or a GI history, a topical Pennsaid or topical Voltaren would be the route to go. Now, 1% is currently available over the counter, but for people with mild to moderate, they might need something a bit stronger, at which point you might suggest 5-10%. This is not going to be the thing that fixes their joint. None of these are going to fix their joint, as a matter of fact. This would be, I would see this as an adjunct to other strategies, which I'll come to. It turns out the ASA-containing compounds topically, according to these guys, the OARSI folks, less effective, less benefit. So you get more bang for your buck if you go with the diclofenac type NSAIDs topically. The next stop, I like to present this information to patients in terms of let's talk about the lowest risk and move on up to the highest risk. And so that's how I presented it here today. So the next stop, the first line of oral analgesic they recommend for arthritis is Tylenol. But you'll see the effect size is very small. 0.2 is small, so 0.14 is kind of debatable. But again, maybe you have somebody on topical Voltaren plus Tylenol arthritis formula. That combination might work better than some of the higher risk strategies. There is a maximum dosing, which I'm sure you're all familiar with. One of the things the OARSI folks suggest you do if you have somebody with osteoarthritis is a Tylenol trial. where you take it every day for at least a week, and at the end of the week, see, is this helping, is it not? That's at a maximum dose of 650 milligrams a time. So you have to be clear on if you're taking cold medication, if you're taking other over-the-counter medication, you need to be checking the label to make sure you're not exceeding that maximum daily amount. So Tylenol plus topical NSAIDs can be a combo that will work for some people in the mild to moderate stage. Moving on, in terms of oral NSAIDs, what's interesting is that the oral NSAIDs, according to these guys, are slightly lower in effect size than the topicals. So as things stand, Tylenol effect size, it goes Tylenol, then non-specific NSAIDs, then Coxibs. It's interesting, now, osteoarthritis has long been described as a disease of wear and tear. However, the fact that anti-inflammatories work so well would suggest that there is an inflammatory component to the osteoarthritis process. And one thing, I just need to go off on a tangent here for a moment. I think it's really interesting how little we know about osteoarthritis. And it turns out obese individuals have an increased incidence of OA of the hand. And so that's obviously non-weight bearing, right? So you got to ask yourself, how does obesity contribute to that inflammatory process? And what is the inflammatory process when it comes to OA? Anyway, back to, so the non-specific NSAIDs that are currently recommended for OA are ibuprofen, diclofenac, naproxen. I hesitate at Celebrex because it's kind of a hot topic. Generally, you guys are all familiar with the special authorization and such. Yes, okay. I spend a lot more time talking about this to patients so that they understand why sometimes a doctor might say, you know what, we're going to go with, you have to try diclofenac first, or you have to try this first. Demonstrate you can't tolerate it before you go and ask for Celebrex. So, one of the things I thought was really interesting is how many people are on low-dose ASA, and then they add a couple anti-inflammatories to manage their arthritis. Then maybe they try a topical. That combination is hazardous. You can only use one NSAID at a time. The goal is to aim for the lowest therapeutic dose for the shortest length of time. Now, according to the OARSI folks, you should be prescribing a PPI with any NSAID, and that includes Celebrex. That was a newsflash to me. Cardiovascular-wise, naproxen is considered to have a safer cardiac profile than in the realm of non-specific NSAIDs. Naproxen is considered to have a better safety profile, although I'm going to show you some tables that would suggest Celebrex. And in terms of kidney function, again, making sure your patient is writing down everything that they're taking to manage their osteoarthritis, because it's the combinations of various over-the-counter herbals plus prescriptions that can take a toll on these systems. So as far as blood pressure goes, when I talk to people, it's like if you're taking an NSAID, you got to get your blood pressure checked. That can be in your office, that can be at the drugstore. It doesn't have to be, like that could be another one of those things you hand off to the patient. I want you to check your blood pressure once a week at London Drugs and write it in your little health log and tell me, like when you come back and we talk about your plan, let's see how you're doing. I went to a rounds with internal medicine, and they figure that there are some people who are using NSAIDs who are experiencing a consistent overall drop in their hemoglobin based on the GI upset. So making sure you're staying on top of the fact that a drop of a point or two in hemoglobin can have such a significant effect on people's balance and health overall. These are some things to think about. And this is the stuff you pass to the patient. It's like, you know what, you're taking something that could affect your heart. That's why you need to come and see me. You know, you set the schedule, but having the patient understand why they need to do this stuff increases their ability to take on responsibility for themselves. So within the OARSI website, here is an algorithm for NSAID risk management. I thought it was interesting. So generally speaking, if you have people who have low GI or CV risk, great, take Advil. But keep track of how much you're taking, and let's check in 2 weeks and see how you're doing. The next step, if there's some degree of GI risk, the suggestion would be to go with, you guys are perfectly capable of reading this table, and it will be distributed to you afterwards. The things I find interesting are Every single option has a PPI attached. In terms of cardiovascular risk, the standing recommendation is naproxen, and only if there's high GI and high CV risk do they recommend Celebrex, or high GI risk do they recommend Celebrex. But this is the kind of information where if a patient presents and is taking sort of random NSAIDs as they feel like it, here are some principles that can guide your recommendation. So what about your people who are on low-dose ASA? What are you supposed to do with somebody who's on ASA? They need anti-inflammatories in order to stay active. How do you manage that risk? Well, according to the Canadian Cardiovascular Society, generally speaking, one NSAID at a time. You either have them on low-dose ASA or you put them on an NSAID for their arthritis. You want to avoid any NSAID and Celebrex type options if there is cardiovascular risk. But as I say to patients often, there are risks in taking medications, absolutely. However, there's significant risk in your pain getting worse and chronic and staying on the couch and becoming deconditioned and more force through those joints. So sometimes it's a matter of how do you balance this risk with the benefits of medication supporting their activity. So I'll leave you with that. You guys will ask questions if you have them, right? Okay. Opioids. Now here's a point that is quite different between the American, the ACR recommendations are different than the OARSI recommendations. ACR, as of April 2012, recommends mild narcotics, which they deem to be tramadol. Now tramadol is considered the better choice as compared to Tylenol 3. Codeine is notoriously ineffective for joint pain, makes you dopey, makes you constipated, makes you a risk for falls, and you still have all the pain in your joints. So, according to the ACR, you should go for tramadol. The OARSI folks pointed out that any form of opioid use represents a risk in all-cause mortality as compared with NSAIDs. So maybe instead of handing someone a prescription for Tylenol 3, maybe you should be talking to them about NSAIDs, or maybe you should be talking to them about topical NSAIDs plus plain Tylenol. Being aware of the escalating risk attached with this group, I would suggest, I've had people show up for joint replacement surgery who are taking 24 Tylenol 3s a day. Those are the people who management-wise, perioperatively, are extremely high risk because they're so tolerant that what it takes for us to get the edge off their joint replacement pain without knocking out their respiratory center, big challenge. So if you have somebody who's in chronic long-term narcotic use, that is not a sustainable strategy with a condition like osteoarthritis. And I think that's a point we could probably discuss at the end if you care to. So, in terms of intra-articular injections, according to the guidelines, cortisone has a moderate effect size, but what joint you stick it in depends on who you talk to, because the ACR group recommends it for hip and knee, but they say don't do it on hand, it doesn't work. The OARSI folks say yes, do it on hands, especially the painful flares of hand OA. According to the research, the effect lasts a few days up to 4 weeks. However, as I'm sure you're all aware, some patients it'll be just that straw that shifts their process, gets them back on their feet, and they may say that they have pain relief for months. Although when I poll my classes, I usually get about a 50-50. It's like half of them say that cortisone's the best thing that ever happened, and half of them say it was hell and I would never do it again. Typically, if they're going to have effect, it's going to be the first time. If you don't get decent effect on the first cortisone shot, the subsequent, it's sort of like diminishing returns. One thing that I always tell patients about, and I'm sure you guys know this, but I just need to say it, cortisone can be brilliant for taking that edge off. And sometimes people are like, yes, now I'm going to go and I had a guy on the yoga mat yesterday, next to me, and I was like, what's the Band-Aid on your shoulder? He's like, oh, I just had a cortisone shot. I'm like, yeah, you shouldn't be here. Oh. So helping people understand that diminishing their pain doesn't mean they should go forth and give her. In fact, if anything, they need to rest and protect that joint because the cortisone shot itself can further compromise the health of the cartilage. Hyaluronic acid. I always picture the Tin Man in The Wizard of Oz getting a little shot in the squeaky bits. So hyaluronic acid, I'd be interested to know in this group how many people are in the practice of doing viscosupplementation. In Vancouver, it's really hard to find somebody who's willing to do it because just setting up the sterile field and getting it into the joint space in the capacity of a physician's office it's not readily available in Vancouver. Although in Powell River, I guess because the patient base is so extremely motivated not to come to Vancouver, they do it a lot. And the patients up there swear that viscosupplementation or hyaluronic acid is the thing that helps them manage their condition, that fixes their pain, that gets them on their feet. The feedback I get from patients in Vancouver is far less positive than that. And it's interesting to me how dramatic the difference is. The theory of intra-articular hyaluronic acid is that it promotes the viscosity of the synovial fluid. It hydrates the cartilage. Basically, it plumps up the cartilage and helps it function better. As you know, when your cartilage breaks down, it's not uncommon for the synovial fluid to almost gel up on those surfaces. By doing a shot of this, you're trying to plump it up and restore some degree of lubrication to the joint. Although, the kicker with this one is that it costs about $300. And so if you have a patient with an extended health plan, they can ask. Sometimes you can get away with submitting the receipts as a medical device. I was about to say something else, I'm sorry. Basically, injectable hyaluronic acid has better outcomes. It's just a matter of having a patient who's willing to spend the $300, who's willing to deal with the crapshoot if it may or may not work. Oh, and that's another thing. So hyaluronic acid, it's meant to plump up existing cartilage. If you're bone on bone and you have like moderate severe joint changes, it's kind of like closing the barn door after the horse is gone. There's not much point in trying to do this if you have bony surfaces rubbing together. Typically, people don't want to spend $300 and have a big needle in their joints until they're suffering quite a bit. So that's one of the kickers of trying to get into this practice is how do you get it timed right so you persuade your patient before their disease is too advanced, and sometimes it's a tough sell. And by the way, the two products are Synvisc and Durolane Synvisc being derived from the rooster comb, and Durolane is synthetic. And I always think to myself, who looked at a chicken and said, you know what we should do? Stick that in your joint. Now, nutritional supplements is a hot topic, and it seems like there's research. Every time I turn around, it's like 1 year it's a yes, the next year it's a no. The Gates study suggested that yes, glucosamine chondroitin does work. The latest research is, I've got the effect size there as moderate according to OARSI. But I don't know what kind of glucosamine they're using in Europe because the outcomes that they describe in the European studies are not matched here. Specifically, they suggest that this supplement can restore damaged cartilage, but that's not ever been the case in North America. So I'm not sure what's going on with that. With any supplement, you are pretty much guaranteed that your patient will say, oh, you know what, my friend is on Sierrasil and it fixed them. And my brain always says, wow, magic dirt, really? Okay. There isn't really research to support that. However, you want to take that supplement? I say power to ya. Let's get clear on what are you doing. So you're going to write it in your health log. You're going to keep track of how much you paid. And in the case of glucosamine chondroitin, get them to be a scientist on their own body. Write down the date that you started. And a month later, how are you feeling? Do you think it's helping? Do you not? Because there's always somebody who's like, you know, I've been on glucosamine for years and it doesn't do anything. To which I say, well, for Pete's sake, stop. And then they say, oh, you know what? It actually is doing something. It's not fixing me, but it sure does take the edge off, at which point they hop back on. Now, things like glucosamine, chondroitin, MSM as a combo are generally fairly benign, but can cause severe fetal abnormalities. So sometimes, you know how you'll have a family where arthritis goes through like every female in the group, and sometimes you'll have a young person who's like, I want to do something to avoid this happening. Well, that's one of those family history type things you have to stay on top of, because again, you're looking to try and create benefit and minimize risk. And sometimes the pursuit of health, people create trouble for themselves. Now next, in terms of nutritional supplements, the avocado, soybean unsaponifiables kind of falls in and out of favor. I would suggest that your patient try one supplement at a time, give it at least a month, and if they're feeling good and they're tolerating it well and they think it helps, great. Now you can add one more. But for those who go to the drugstore and fill their cart and take fistfuls of everything and then wonder why they feel bad, that's a very expensive, high-risk way to figure out what's going to work for your arthritis. As of these publications, there is not evidence to support supplements like vitamins E, D, C. There isn't evidence to support the green-lipped mussel supplements or SAMe, but I know lots of people who swear it works great. And so I say, by all means, carry on one supplement at a time. How much are you spending? And if you want to add one more, talk to somebody. The Arthritis Information Line is a fantastic resource you can be giving your patients. If somebody says, you know what, I want to take supplements, but I don't know where to start or what to take, and we're out of time, great. The Arthritis Info Line has access to databases on supplements that I don't actually have access to. So I would encourage you to hand out that phone number. Also, I would encourage you to educate your patients. They'll say, you know what, I've heard about this hot new arthritis remedy. Find out, is it osteoarthritis? Is it meant for rheumatoid arthritis? There are thousands of supplements. A lot of them are about modifying the old immune system. How does your patient choose? Well, they can phone the information line and say, you know, what's the deal with evening primrose oil? Or what's the deal with omega-3s? What should I take? How should I do this? Getting information and having somebody you can talk to for an extent, this isn't a 5-minute conversation. This can take a while to figure out what's their current nutritional state and what are they trying to support. So, the non-pharmacological, so that's it for pharmacological strategies according to the table in OARSI. Are there any questions or comments? Has anybody found any of those or just delightful? Yes. You know what, so the question is, what do I think of collagen orally? I've heard of a lot of different supplements that are meant to support cartilage and connective tissue health. Right now there's a hyaluronic acid as a pill. There's collagen as a pill. There are many, it seems like any strategy, like previously topical, now it's a pill, or previous a pill, now it's a shot. There is not currently research that supports that. And I would sort of question if the GI tract would even allow that molecule to get anywhere near the damaged joint. However, if somebody wants to try it, or somebody feels that it's something that they want to do, you can say to them, you know, there isn't the research to support that. However, let's get science on this. Write it down in your book. Talk about, do you have a belief around collagen?
I use it myself. It works fabulously.
Awesome.
So I am advocating it, and I've had some people say yes, it works.
I've had people advocate for oral hyaluronic acid, and it's something I can't conceive of how that would work, and yet they say it does, and I say yay.
In my mind, it's witchcraft, but for some reason it works.
You know what? I think sometimes we have to suspend our disbelief and support people's desire. If somebody is taking action to support their health or support the health of their joints, I think our job is to cheer them on, not to poo-poo it, with a pragmatic approach. So I would support that. Would I recommend it to somebody out of the gate? No. But I would support you recommending it out of the gate. Are there any other strategies people, or were you going to say something?
I had a question.
Oh, please.
For cardiac, when you're setting naproxen over ibuprofen,
Yes.
ibuprofen is less safe than naproxen.
So the question is naproxen more safe than ibuprofen cardiovascularly? According to the OARSI folks, as of today, yes. Naproxen is considered to have a better safety profile, and they specifically articulated that in a number of places on the website. So that's why I included it here.
Does it smell?
I bet it does, and I would have to defer that one back to you guys as a group in terms of dosing. Do you have any thoughts on the subject?
No, I just think it's interesting. I mean, now I guess you can buy naproxen over the counter at low dose.
Mm-hmm.
But people are out there just having free access to ibuprofen,
Yeah.
using it. So I wouldn't have necessarily thought to say, what are you using it? Oh, you also have hypertension or other.
Yeah.
Yes, you shouldn't. I'll give you this NSAID instead.
I strongly agree with you. I find it bizarre that you can walk into the drugstore and fill your cart with calcium and aspirin and ibuprofen and take fistfuls of it thinking you're doing the right thing, and you're actually putting yourself in harm's way. Like the risk profile is quite high. And that would, so yes, isn't it weird that Advil is free and easy and naproxen is prescription? Go figure. I don't know why. Was there anything else? Yeah.
Just a comment, when you are talking to people about supplements, make sure they're not shark origin, because we're the last 15 years just about eliminated sharks from the world. I scuba dive and we need sharks. So
Absolutely.
ask if you've got a choice, ask.
Well, and that's, I think it's really, one of the good things is we have an opportunity to dispel myths. Like, so the cartilage in my joints are worn out. I should eat cartilage. I'm going to eat shark cartilage. You can kind of see the logic, but really from an environmental standpoint and from an actual, back to the point of, so here's somebody who takes collagen orally and it helps. I think there's some value to thinking about what can I eat that supports the health of my cartilage. And as a citizen of the world, how am I not contributing to depletion of crucial animals? Absolutely. So, moving on. Here are the non-pharmacological strategies. And what I would hope is that if you have a patient with osteoarthritis and you hand them a prescription for a medication, I really hope you hand them a prescription for a non-pharmacological strategy at the same time. Back to that, it took a lot to bring them here to having severe joint disease. It's going to take a lot to try and undo and control and maintain the health of the joint. So the items that are currently supported by research are exercise, acupuncture, thermotherapy, TENS, diet, footwear, and walking aids. So I'm just going to go through a few of those. And this is, and again, back to that idea of it takes a village, it takes a team led by a patient to manage and delay the progression of the disease. I recognize that the cost of arthritis management really gets up there, but if you have somebody with mild OA who has an extended health plan, referring them to a physio, doing what it takes to strengthen the quad of the affected leg as well as the unaffected leg, lengthening their hamstrings. We have handouts on exercises you should do for OA, but as we all know, it's really hard to do good technique, and you don't always understand the mechanics of your own body. So sometimes a referral to a physio is the route to go. Now, according to the OARSI folks, water-based exercise does not have a measurable effect on certain effect sizes with pain, function, and stiffness. Sorry about that. However, water-based exercises is the number one thing we recommend to people with OA, more in relation to the fact of just trying to get the gravity off of those damaged bony surfaces. So we consistently recommend getting in the pool anytime you have OA. Of course, you have to temper that with the fact that for some people, bathing suit shopping is just not an option. And so this may not be the recommendation for everybody, but there are people who, if they get in the pool, if you're in the pool up to your waist, that's half of gravity off of your painful joint. If you're in water up to your neck, 90% of gravity has been taken away from that joint. So let's say you've got a runner. Maybe you've got a young woman who's a runner and she's blown out her knees after a lifetime of high-intensity sports. You can't tell her to get on the couch, but you could tell her to get in the pool, put on one of those buoyancy belts, and do deep water running. And in fact, that's what one of the people in our DVD does. So if you have a patient like that, send her to the DVD and say, see, here's a young, fit woman who's like frustrated and found an alternate strategy to staying active. Other things, so strengthening aerobics, small to moderate effect size, But again, are we trying to treat the diagnosis, or are we trying to treat the person? Are we trying to promote their health in all ways? And I think that can be done in a variety of strategies. So for some, it would be send them to Aquafit at the pool. For others, it's hook up with a personal trainer. I think there's a small percentage of people who would respond well to our outline of water-based exercises. So you can go to our website and get that handout if you like, and then laminate it so they can take it to the pool. So physiotherapy, I was surprised at how strong the effect size was for thermotherapy. But again, you can't just randomly assign ice or heat. It depends on the state of the joint. Ice is generally the route to go when you're having an acute flare-up. But if you have somebody who's had chronic long-term arthritis, and you know how they get sort of waxy, it's like chronic swelling around the joint, putting ice on that is actually going to aggravate that because you're actually diminishing blood taking that swelling away. So that's when I think a physiotherapist would be good, especially with hand stuff. If you have somebody who's got those early, like surprisingly acute flares up of OA in the hand, a physio who specializes in hands, or even just a general physio who can work with the person in terms of ice and heat and contrast therapy might be a really good strategy. TENS machine, I'm sure you're all familiar with, surprisingly well supported in the research. Although I don't know if I trust the Dr. Ho late night option, but he has a device he sells on TV. However, with a TENS machine, you can buy them. They're about the size of a clock radio, cost about $100. But again, you don't want to be sending them to spend that kind of money if it doesn't work. So go to the physiotherapist, have a trial of TENS. If it works for you, great. It's an adjunctive therapy. Maybe you take some Tylenol arthritis and put on your cream and add your TENS, and then you can watch a movie in peace for an evening. So it's not going to fix them or eliminate their pain, but it does go a long way to helping them get some pleasure in life by taking the edge off. Now, acupuncture is small to moderate. There's less research to support IMS as a delivery system. Do you guys know the difference between IMS and TCM? Yes, no? Yes, no? Okay, I got some no's, so I'll explain it. Traditional Chinese medicine, that is the form of acupuncture that has been researched primarily and has been found to have moderate effect size. So if you have a traditional Chinese medicine doctor in your neighborhood, referring a patient for OA treatment there might be something that, well, I don't know if you would actually do that referral or if you would just support the patient who comes in and says, here's what I'm doing. IMS was a strategy developed by a man called Dr. Peter Gunn. He received the Order of Canada, and his approach is to take the acupuncture needle, and instead of trying to apply it along the meridians to promote the flow of qi, he takes the needle and places it into tetanic muscles, because when you have a chronic long-term change and your body is contracted trying to get off that painful joint, sometimes those muscles, they have become tetanic and they've forgotten how to relax. So you take that IMS needle and stick it into the contracted muscle, and it puts it into a refractory period. I'm not going to lie, apparently it hurts like a lot. It's a very, very intense, exquisitely painful type strategy, so you got to be careful who you recommend it to. However, people have had significant restoration of their alignment. And given that misalignment is such a big part of arthritis, you can take the edge off their pain and promote some symmetry. It seems like a good idea. But like I said, I don't have research on that one as much as I do on the TCM type. And I know a man a doctor of traditional Chinese medicine doctor in Vancouver. He has an approach where he treats it almost like chemo, where he doses the person twice a week for 4 to 6 weeks. Then he pares it down to once a week, then once every 2 weeks. The longer you've been suffering, the longer you need the intensive treatment. His version, if you follow his game plan, it's about $2,400 a year. Not appropriate for a whole lot of people. But there are some people you might find that have the money and have the interest, and that it may align with their values, which is tremendously valuable. So I leave that with you. A little bit more on the non-pharm strategies. So as far as nutrition, so you've got, I've had people ride in on scooters, like morbidly obese people ride in on scooters for my pain class and then ride on out for the weight control class. And I'm like, come back. Sometimes when, as you know, when someone has long-term entrenched obesity, the you need to lose some weight piece is can be really just like a pipe dream almost. So I try to put this in the context of a small weight loss represents a tremendous shift in the amount of loading force through the joint. In the case of OA, 1 extra pound of weight equals 4 to 6 pounds of force. That's the weight on the body or the weight in their bag or the weight in their groceries. So talking to people lifestyle-wise, how much weight are you putting through your joints and what part of that can we pull back on? Having people understand that, you know what, you can't say to somebody, you need to lose 100 pounds. But you could say to somebody, you know what, how about until, let's say for the next month, you add 1 green vegetable a day, you add, like come up with some small manageable things that may have an effect on their habits and their weight. The OA diet that I put it in quotation marks, fruits and vegetables, tons of minerals, antioxidants, of course those are the right choices for healthy joints. Generally speaking, there isn't like a diet per se in the research that will help, but what is going to help joint health is going to help systemic health. So, just want to bring your attention to that handout I mentioned in the beginning. There is a Protecting the Joints in Your Feet handout. I don't know how many times you see people who have, you can see they're obviously severe valgus and their shoes show it. Maybe your prescription is it's time for you to get a decent pair of shoes. Because when you don't have the cushioning in your joints, you should have cushioning on your feet at least. So for some of you, if you have people who have severe malalignment, give them the handout on how to choose shoes well or how to protect those joints in the lower body. I see a lot of people out in the world using walking aids. Walking aids can take, I've got 5 minutes left. Wow. I don't want to talk about that anymore. Oh, yay. Okay, I wasn't too far off. I'm sorry. I do want to come back to this. Nordic pole walking is kind of our latest, greatest thing. With Nordic poles, you know how with a cane or a walker, you see people, they're using their husbands' or their wives' devices and they're not using it right and they're sort of shrinking and contracting. If you have someone with a walking aid, making sure it's adjusted to the proper height and they know how to use it. If you can do that in your office, I say thumbs up, or perhaps they need a referral to an OT. The Nordic walking poles, on the handout I gave you, there's an occupational therapist in Vancouver who developed these poles specifically for people with osteoarthritis. So if you have any interest in the concept, we've got lots of resources and ways to we're creating Nordic pole walking groups because when you got those poles in your hand, you got better posture, you got better alignment, you're breathing deeper, and you can see some of our people on the DVD going for pole walking under the cherry blossoms, which is inspiring to me anyway. Having said all of that, I kind of figured